Kia ora and welcome to Menopause and Arthritis, the podcast where we break down the dual challenge of managing menopause and arthritis. Ko Joe Miller toko ingoa. Hi, I'm Joe Miller from Arthritis New Zealand, Mata Pona Pona Aotearoa, and I'm here to guide you through expert insights, real stories, and practical advice to help you manage your health with confidence. A little bit about me. I'm currently training to become a psychologist, and I provide mental health support as part of our Arthritis Assist services. With an interest in women's health and aging, and having gone through menopause myself, I'm passionate about increasing awareness and helping women manage this stage of life, especially with arthritis. Each episode will chat with subject matter experts, health professionals, and advocates to uncover what's really going on with your joints, hormones, and overall well-being. Whether you're navigating symptoms yourself or supporting a loved one, this is the place to get the knowledge and support you need. So let's get started, because understanding your body is the first step to feeling your best. Kia ora and welcome to episode 2 of our Menopause and Arthritis podcast series. Today, our podcast guest is menopause expert and Dr. Samantha Newman. Sam is a GP based in the Hawke's Bay with a particular interest in women's health and well-being. She lives and breathes menopause, and she wants women to take control of their health. She also has an interest in musculoskeletal health and pain management. So we've been overwhelmed with questions on joint pain from our community, and Sam is going to help answer some of the questions around this today. She'll look at the impact of hormones and how to manage pain, the benefits of hormone therapy, and finally she's going to give us some tips on how we can get help from our GP and the best ways to talk about menopause and arthritis. So welcome, Sam. Great to have you here today. And before we start, I thought it'd be nice if you could just tell us a little bit more about yourself, explain what you do, how you work with women, and why you're so passionate about menopause.
Yona, thank you so much for having me and for the opportunity to talk about things that I see daily but aren't really kind of thought of as being commonplace as such. So I'm a GP. I'm originally from London, and the Hawke's Bay is now my forever home. Been here just over 12 years, the whole time in Hawke's Bay. I started off training in obstetrics and gynecology. And then while working as a registrar here, I was always quite scared and not a nice person, not the person that I wanted to be, and not why I think I went into medicine when I was stressed and worried about getting this baby out as quickly as possible. And I had my patient Zero, who really showed to me how health is a journey and understanding the different stages of female reproductive health and what it means to not only the wahine but the whānau as well. And it was a bit of a kind of a light bulb moment, and I was on the plane going to England to spend the last time with my grandma before she passed, when I was like, what am I doing? I need to do GP and I need to specialize in women's health. And that was kind of it, really. And so I went back and did obs and gynae for another year and focused on what would I need to know to be a really good community women's health doctor. And then, boring, long story, so I'm just going to say in a sentence, to improve access to women's healthcare in Hawke's Bay, I had an opportunity to start a kind of a clinic at the local centre, supported by some nurses that were there in the building at the same time. And yeah, 7 years later, through my patients, I've just seen incredible patterns and heard really life-changing and practice-changing stories about what hormones have done to women, and how they've experienced it. And then through using, the tools in my kete, how symptoms have improved. And that's how I've, in essence, learned about hormones and how I've been guided into menopause medicine, because it's amazing. It's really incredible putting pieces of the puzzle together. So yeah, that's why I'm kind of here.
Oh, Sam, that's fantastic. I think the Hawke's Bay is very lucky to have you there, and I think we are in New Zealand as well. And those blinking hormones. So yeah, can you explain, yeah, I guess a little bit about more about what menopause is, and then also that connection of why women in perimenopause get more pain, and I guess why this is important. That would be fantastic. Thanks.
Okay, so I think to really understand any of that, we have to go back to the basics. And if we think of what the menstrual cycle is, and I'm quite visual, but I'll try and describe it to the best of my ability. So in essence, every single month, day one, when we start menstruating or bleeding, then our hormones are low. And we're talking about estrogen. So estrogen is a hormone. It's one of the main female reproductive hormones. So in essence, it's a messenger. It goes from one part of the body to another part of the body, to tell it what to do. And in our menstrual cycle, as it's rising, it's going to trigger ovulation, so releasing of an egg mid-cycle. Then estrogen drops and then it rises again. And that's the normal menstrual cycle. So low estrogen, estrogen rises and peaks at ovulation, then generally drops and then rises again. And the other main part, when we look at the menstrual cycle and how that impacts pain and well-being, is generally progesterone. So progesterone is only released from ovulation. So we ovulate 2 weeks before our period comes. So that's at about day 14. And from day 14, we produce progesterone. And so that rises and falls over a time period of 2 weeks. So for the first 2 weeks of the menstrual cycle, you've got estrogen change. And then for the second 2 weeks of the cycle, you've got estrogen and progesterone change. And so then when we come into perimenopause, what's going on? Well, we know that from our mid-30s, our fertility rates drop. And one of the contributing factors is that we produce less progesterone when we ovulate. So perimenopause, some of the symptoms are from lower progesterone. In perimenopause with estrogen, and this I didn't know until, I got deep dived into hormonal health, and was real game changer for helping me understand what's going on, is that, and this is how I describe it to my patients. So for the scientists out there, it's not 100%, but it pretty much conveys what's going on. So the beginning of the month, the brain releases a hormone called FSH, follicle stimulating hormone. And that's how the ovary releases estrogen to get an egg to release. However, the ovary is getting a bit tired in perimenopause. It's like, I've done all the hard work. I've built your bones. I've made your heart work. I've built your muscle. Give me a little rest. And so the brain shouts louder. And so the FSH rises even more. And then the ovary kicks in and bam, estrogen is released and estrogen surges. So to higher levels than even at puberty when we're finding out about our hormones and what happens. So we have this big peak of estrogen at ovulation. Then generally the estrogen drops and then it rises again with progesterone. However, some months it doesn't drop and it goes up even higher after ovulation. Other months, it doesn't really rise much at all. And overall, throughout that perimenopause transition, there's this huge fluctuations, but a gradual drop, so decline in estrogen. So in the perimenopause, there's actually a lot of hormone change, a lot of ups and downs. And that's a huge misconception, really. And we'll come back to it when we deep dive into pain a bit more. But I think as a female, understanding that in essence, every week or every 2 weeks, the really important chemical messengers in your body are changing. And then it makes sense we're going to feel different. And then in post-menopause, so the brain is still releasing FSH and the brain is still kind of shouting at the ovary. And this is why the FSH rises and it stays high. And we have no estrogen and we have no progesterone. So it's normal in perimenopause to have low progesterone and extremely normal to have very low progesterone and estrogen at postmenopause as well. So we don't need blood tests to ascertain this, to figure this out, because it's all about you as an individual and how you experience things. One of the things to be aware of is that the average age for menopause in Caucasians, Pakia, is about 51. And it's thought to be probably about the same in Maori. In Asians and Indians, it's 45. So that's a huge variety in essence as well. And perimenopause can last 10 to 15 years. So if you have an average age of 51 in a Pakia, well, mid-30s is really reasonable to start getting these changes. And in Asians, well, that's even earlier. But we do want to do blood tests to make sure individuals, to make sure our wahine are not experiencing menopause, preferably under 45, but definitely under 40. So menopause under 40 is known as primary ovarian insufficiency, used to be known as premature menopause. And I did touch on the benefits that estrogen has with respect to bones, brain, heart health, skin health. And we know that if we go through menopause under 40, and that happens to 1 in 100, then the risk of chronic disease significantly increases. So we really want to identify that. And in our wahine under 40, you shouldn't be having, a high FSH test is abnormal, and I would be recommending hormones. That's very different from the natural menopause when someone is older and you don't have those health risks.
And that's really interesting, because I know there's some research as well that links that early menopause to arthritis as well. Certainly the risks of developing, I think, particularly rheumatoid arthritis is much higher if you've gone through an early menopause. So that makes so much sense when you talk about the hormones like that. And I think for our listeners as well, that level of introduction to hormones is really, really interesting, and suddenly makes it so much more understandable, which is great. So I guess the next thing is why do they so often get more pain? I know there's a lot of talk about joint pain. Sometimes it's arthritis, sometimes it's menopausal. And what is that link, Sam?
So if we go back to the menstrual cycle and look at the role of estrogen. So estrogen is an anti-inflammatory. So when estrogen drops, we get less of our own anti-inflammatory. So our inflammation increases. So for those who have had leg waxes pre-period, you'll know it's more painful than at other times of the month. So therefore, as we go through the different stages of the menstrual cycle, our pain levels change. And so post-menopause, when we've got less estrogen, we may experience more pain. Also, pre-ovulation, we need to be feeling our best, because that's what we need to do to reproduce. So it's understandable then our body has adapted to release more estrogen to manage the pain. Also, with respect to progesterone. So progesterone goes high in pregnancy, and that's to cause rest and digest, relax and relaxin, because you need the hips to get bigger and to make more space under the ribs and in the tummy and the pelvis for baby to be birthed through the vaginal canal. And so if we think of what progesterone does, is it causes ligament laxity, then premenstrual, when progesterone's levels drop, then actually we've got increased rates of pain, of ligament sprains, of injuries as well. And there's increasing evidence for individuals who have experienced things like ACL, so anterior cruciate ligament injuries, and following repairs, doing rehab based on your menstrual cycle. So pre-ovulation, when estrogen's rising, testosterone is also rising too. So we're going to have the most muscle bulk development. So doing some good exercise then will really help build the muscle to protect those joints. And then premenstrual, adapting it accordingly as well. Um, Also, estrogen is part of, and it helps with the water content of our tendons. It helps with the flexibility. So as estrogen drops as we get older, the flexibility of our musculoskeletal system drops. Also, estrogen acts as an anti-inflammatory in the joints. So once again, that makes sense why we get more joint pains. And then it's really tricky, I think, and we don't really know in essence because, it's a bit like what comes first, the chicken or the egg. But I think if we actually stand back and say, well, for whatever reason, I'm getting older, my estrogen's dropping, I'm not moving as much, so my muscles aren't protecting my joint. And this sets up this vicious, like, pain cycle. And I often use it like deconditioning. So you stop doing as much, so you get less fit. And so it hurts more and it causes more pain, and you've not got the protection around. You lose your core. So the activation of your pelvic muscles, the back and tummy muscles are all really important. And just because I always go off on tangents, unfortunately in life, but one of the things that pregnancy and with women's health is the flexibility. And so if you have a hip injury or a knee injury, then often you change how you move. So that puts other stresses on different areas of the body as well. And so it's really important to kind of put all of this together, and it's often really complicated. And I think even what we've talked about so far, if you've got pain, I think that you've got loads of little light bulbs going off in your head. But as we go through, we'll try and break it down a little bit to help you make sense of what's going on to get the best outcomes, particularly as this is a really new space for a lot of us, healthcare professionals included.
Yeah, you're so right, Sam, because there's a lot of confusion around joint pain and arthritis and what the differences are and which is which, and how to talk to your GP. I think about that as well. And I know there's this new phrase out there, because I know you've just been to this conference in Sydney on menopause as well, called the musculoskeletal syndrome of menopause. And I'd love to just hear some of your thoughts around that, and what that means, and some of the research that's been done around that, and how, I guess, women with menopause and arthritis can maybe use some of those learnings as well.
So this is so interesting because how I have realized this association is I've got a patient who I knew through other ways, and she came to see me. And she had been on a medicine called quetiapine for a number of years and post-menopause to improve her sleep. And she had had an ankle fracture a few years ago, and she kept putting on weight with this medicine and had heard that HRT can help with sleep. So for one, as a doctor, I would be not going by guidelines, starting someone who is 54 on HRT for sleep. So we'll come back to that. So I said, okay, well, you've had postnatal depression, your symptoms, your sleep went off at menopause, you're putting on weight with quetiapine, it's not good for your blood pressure, your cholesterol, hormone replacement therapy, and we'll talk about exactly what this is later. The benefits outweigh the risks based on that, so let's give it a go. So her sleep improved within a few days, which is always just really great. Doesn't always, but it improved in a few days. Then I saw her a few months later, and we'd increased the dose over that time. And like one of her passing comments was, Sam, I can now walk the local hills because my ankle doesn't hurt anymore. And I thought it was due to that fracture. And so that's 10 years post-fracture. And I just remember being like, whoa. And so then, because I'm a pattern seeker, I like evidence. I like putting things together to support my patients. And whenever I do work with my patients, I want you to feel confident in our plan. And I've seen a number of women now, and they say their body pains get better. And so that's when, for me, and when I ask, how was your experience with HRT, that I have this brilliant, beautiful insight into what was your life pre-HRT like and post. And so then I get to see this improvement in pain. And I think before we dive into musculoskeletal syndrome of menopause, understanding what menopause is. So traditionally, menopause was thought to be hot flushes, and that's why you should have hormone replacement therapy or the non-hormonal management things. However, actually, we find anxiety, cognitive symptoms, sleep disturbance, fatigue, overwhelm, anger, irritability. You hate the noise of your husband breathing, the smell of the laundry, just that rage and irrationality. And none of that is hot flushes. And so even if you look at pain in a context of that, in a context of someone who's not sleeping, someone who can't fill their cup like they used to, well, pain's going to get worse. Because we know that when you're depressed, pain worsens, and being depressed worsens pain. We know pain's worse when you can't sleep. And also, sleep disturbance drives us to eat more because we're in a survival stress mode. And what does weight gain do? Weight gain increases inflammation, and it causes weight gain, which also can exacerbate joint pain. And if we would look at menopause as just hot flashes, we miss all of these things. But I did a presentation a few years ago on body pain and menopause, and I found papers back from the 1900s talking about body pain in women at menopause. And I'm like, what? Like, this isn't new. And so when I saw a paper, and we're going to have a link to this paper in the show notes, and you're going to treasure this paper, and everyone will, and you'll know why. Called musculoskeletal syndrome of the menopause. I was like, this just makes sense to me. So it describes the relationship about hormones on the musculoskeletal system. So that's ligaments, that's tendons, it's bones, it's muscles. It's not, it's not just one thing. And it also talks about the different kinds of symptoms of menopause. So we've touched on arthritis and probably more the osteoarthritis. So, increased kind of wear and tear. So the estrogen not supporting the collagen and the cartilage as much, causing inflammation. But we haven't touched on autoimmune and inflammatory joint diseases. But as estrogen's involved in inflammation regulation and autoimmunity, when that drops, this is also why autoimmune diseases in women become more prevalent at menopause and postnatally when hormones drop. One of the things, actually, no, so there's a couple of other things that we notice a lot more at menopause, and frozen shoulder is one of them. Plantar fasciitis, Achilles tendonitis, and it's because of these changes in hormone levels. One thing that the writer didn't talk about is one of my new passion, well, is it new? I don't know, kind of passion projects is the concept of fibromyalgia. And this is really out there, and don't go saying this to your GP without backing it up, because they'll be like, they won't listen and they'll think I'm crazy. And I don't want anyone to think any of us are crazy. It's fibromyalgia, because fibromyalgia is, chronic pain associated with depression and fatigue. Oh, perimenopause, pain, depression, fatigue. So is your fibromyalgia associated with itchy skin, with ringing in your ears? Does it worsen premenstrual? Because I'm not saying every body pain is related or is caused from hormones, because we're going to have a lot of dissatisfied individuals if we say everything should get better with hormones. But I would really, challenge anyone to diagnose fibromyalgia for a woman in midlife or having menstrual cycles or on contraception, because we don't know what the hormone's doing, without a trial of hormone replacement therapy.
Oh, that's just absolutely fascinating, Sam. I love that. I think it's something, it feels like so much of this stuff is coming together. People are already talking about it. They're starting to make sense of things. And just you talking then, I was going, yes, that's me. That's all that stuff. And it makes, yeah. And suddenly it's all making sense. So, yeah.